This is a version of the presentation given to Lundbeck on the 24th of June 2019, and we're just doing it again for anyone that wasn't at the presentation so they can see what we said at that presentation. Okay, so Machine Medicine is a London-based startup founded by myself. My background is as a doctor, a machine learning engineer, as a neuroscientist, and I was working as a doctor until about 2.5 years ago when I left neurological training in order to start machine medicine and try and make an impact by combining my technical background and clinical background. And our long-term aim is the same as many machine learning focused med tech companies, and it's the holy grail of achieving patient prediction, and that includes things like personalization and patient selection for particular therapeutics or indeed for clinical trials. I'm going to use some particular terminology in this presentation, and I just want to point a couple of them out. Most people will be aware of the UPDRS score, the Unified Parkinson's Disease Rating Scale, and in particular the Movement Disorder Society's version of this is now largely regarded as the gold standard in terms of clinical assessment in the context of clinical trials, but also in certain therapeutic scenarios within clinical practice, in particular for the pre-assessment of people that are being considered for deep brain stimulation. So we're going to refer to two separate UPDRS scores. One of them we call the C UPDRS, C for clinician, and this will be a UPDRS score that's given in the traditional fashion. A trained clinician will be having the patient perform particular activities around 16 in the UPDRS Part 3, and for each one he or she will associate a particular clinical score between 0 and 4 with that activity. The KUPDRS, we mean by K Kelvin, which is the name of our AI-powered platform, and a KUPDRS is an estimate of what the UPDRS score should be as produced by the platform. So this is a this is as it were a machine estimated version of the UPDRS. There's no human involved in making this estimate, except insofar as we've used CUPDRS data in training the system. And one of the ways of thinking about how the system works is as a kind of wisdom of the crowds, whereby it averages over all of the assessors that have been kind enough to put data into the system, and from that is able to estimate a much more precise and reliable score than would be possible from a single assessor, no matter how qualified that assessor might be. Okay, so without further ado, I'll just briefly outline what we're going to talk about and then set. We're going to outline the problem. We're going to talk about our solution. We're going to talk about exactly what it is that Kelvin is measuring and how we extract the features and the particular details that Kelvin uses in order to make its estimates. And then we're going to look at a very specific use case. In particular, we're going to try and estimate a global bradykinesia score, and we're going to do so using only the specific tests that are relevant for an overall score of bradykinesia. So we'll talk about that in some more detail later on. Finally, we're going to circle back and talk about the data that has been used to train the system, and present some evidence that the data sets that we use are essentially equivalent to the data sets that are in broad use across the field. And in particular, we're going to make the claim that our patients cover the sort of spectrum of disease in roughly the same way that Parkinson's patients across the globe do. We've got a couple of appendices that I won't go into on this in this presentation, but for reasons of brevity, we put many of these figures into the appendix, and I'd be happy to talk to anyone who's got any particular interest in any of them, either offline or on a particular call. Anyway, okay, so the problem we're dealing with is essentially one as old as human perception itself. and it's that the mind plays tricks on us, and what we think we see is very rarely what other people see in any precise sense. So here, many people will see a rabbit, but just as many people will see a duck, and you can have a debate, philosophical in nature, about who's right or who's wrong. But the bottom line is that there's no agreement about the state of affairs in the world, even though there is a particular state of affairs in the world. Now, this is a trivial problem in this case. It's just a sort of toy example. But when we get into the context of the clinic, then we come across situations in which this has real impact. So this gentleman has Parkinson's disease, and he's being assessed using one of the classic tests in the battery of tests that's used to assess the motor component of Parkinson's disease, in this case finger tapping. He's asked to tap his fingers 10 times on the right, 10 times on the left, and then the clinician will be observing him do this and will be looking for particular traits or features that are characteristic of the disease, and from that he or she will make an estimate of the disease severity, and as I mentioned previously, score him for each item on a scale of 0 to 4, with 0 being essentially normal and 4 being essentially unable to perform the action because of the Parkinsonism. Now, I used to do these assessments myself when I was training as a neurologist, and I remember thinking at the time that the data I was collecting was complete junk. And having talked to colleagues and looked into the literature, it became rapidly evident that in fact nobody is any good at doing these assessments, and in fact subjective endpoints is one of the greatest problems facing the development of new neurotherapeutics today. And ironically, in the area that can least afford it, CNS disease, central nervous system disease, being the greatest unmet need in the whole of medicine, the greatest burden of disease. So people have known about this problem for many decades, in fact, and they've come up with what I would call engineering solutions. So if an engineer is asked to measure movement on a bridge, then what he does is he typically attaches an accelerometer to it. And this is the engineering solution that people came up with in the case of Parkinson's disease as well. Thus, do we have accelerometers for the finger, for the wrist, for the elbow, and we call this the Christmas tree solution because it's no solution at all. This kit is expensive, it's difficult to use, it's inconvenient for the patient, it needs to be cleaned, there's potential infection risk, it's a nightmare from start to finish. And then, at the end of it all, the data is extremely hard to analyze. So this is the reason why very few people use this equipment in their clinical trials or indeed in clinical practice. Now, machine medicine, we have come up with a radically different approach. Our solution, Kelvin, requires nothing more than the monocular video clips that can be obtained by using any standard smartphone or tablet that's available on the market for between $100 and $200. From this video that we can capture through these commoditized devices, we can then split the videos into frames, and for each frame use a technology called pose estimation to track the precise location of the patient's body, and using that frame by frame we can extract a high dimensional time series that represents the patient's movement. So here in this example we're looking at the XY position of the right hand while the patient does the activity of finger tapping. So you can see there's some sort of periodic structure here, and you can arguably even detect some reduction in amplitude with the eye of faith. But the deeper point is that that we can take this kind of information and characterize the patient's movement in a completely objective and in fact much richer way than was previously possible. And from that we can then extract biomarkers of disease severity. So here we're looking at a classical biomarker of finger tapping, which is a reduction in frequency, and this is compared between patients that are off medication and patients that are on medication, in particular levodopa, and we see, as we would expect, a robust reduction in amplitude, reduction in frequency when people are off medication relative to when they're on medication. So what does this look and feel like for the actual users? Well, it's basically extremely simple, in fact as simple as we could make it. So what we essentially did in the first instance was to take the standard UPDRS form that was being used as a sort of pencil and paper assessment form, and we digitized it, and we embedded video capture within this digitized version of the UPDRS form. And that means that people can just do exactly what they were doing previously, except now they're doing it on a tablet, and some of them are already doing it on a tablet, but if they weren't, then they are now. And they're able to capture a discrete video clip for each particular activity. From a machine learning perspective, what we say about that is that is our source of labeled data. Rather than having a single clip of, say, 30 minutes of a patient performing all of these activities and a UPDRS document that contains all of the clinical scores, we now have discrete clips where we know a patient is doing a particular activity, such as, say, finger tapping or walking, and we know what the clinical score given by the clinician for that particular video clip for that particular activity was. Now, putting all this together, what essentially happens is the user opens a digitized assessment form. They can capture a video within the form. The video is recorded and uploaded to the cloud, and from there the biomarkers are automatically extracted. So it really is an extremely simple user experience, and one that's actually, in terms of the user experience, one that's extremely close to what's happening today. Now I'm just going to briefly come out of this presentation to show you a short 1.5 minute video of a patient actually being recorded. So this is a recording made at UCLH in London with a patient who's given us permission to use his videos to demonstrate the product. And there's a couple of things that are interesting, I think. So the nurse is just recording this at the moment, and some of the interesting things relate to what we would call unintended consequences of building this platform. And one of them you can see here. So the nurse is re-watching the video. She's already watched the patient while she recorded the video, but now she re-watches it. She scores the right hand, and then she goes back and watches the left hand. So she's now watching the patient for the third time before she does the score. But you find that she hesitates, and then she goes down to the instructions, refreshes her memory as to what the particular criteria are, and then goes back and watches the video one more time. So for a fourth time, and only then does she go down and score the patient. And what we think this is doing is that it's empowering the assessor in and of themselves, even before we've done anything particularly clever with the AI. So as we'll go on to show later on, our proposed solution for the optimal score is not in fact some superhuman AI that performs independently of people, nor indeed is it to use the current technology, which is human assessor, which we've already stated is inadequate in many ways, but rather to combine these two sources of information in order to obtain an optimal score. And in fact, we can improve that score by either making the assessor's scores better, and that's what I think we're doing here, or by making the AI better, and by feeding the system more and more data. That's exactly what we're doing. So we've talked about the user experience in terms of data acquisition. What do the analytics look like? Here we have a display from our online analytics platform that shows you what the data looks like once it's been uploaded and processed, which takes a few minutes. Here we have the original source video. And here we have the pose data that's being extracted from that particular frame. And here we have a time series of what's being extracted. So in fact, what we're looking at here is the distance between the right hand, thumb, and index finger. So the distance, the Euclidean distance measured in body lengths. So we estimate the person's size and track that. And then we're measuring his movement in terms of the distance between his thumb tip and his fingertip over time using this pose estimation. You can also see some, You can also see some other clinical features, such as the actual CUPDRS, which was given by the assessor. If you want to, you can download any of the data that you might require, or you can specify a particular region of interest and download the features and the data from that particular region. So what exactly does the analytics look like? How exactly are we going about extracting these features? So I'll walk you through one or two, and that should give you some flavor of how exactly this technology works. This is a figure that we've seen briefly before, showing a three-dimensional representation of finger tapping, so the XY coordinates for the right hand on a patient who's performing finger tapping. And the first thing we can do is we can use a combination of domain expertise, so clinical knowledge, combined with machine learning techniques that tell us what the most informative time series are in order to eliminate a bunch of data points that aren't relevant for what we're trying to measure. What we've actually done here is we've eliminated all of the data points except the thumb tip and the fingertip, and you can see that we have a vastly simplified pair of time series, so bivariate time series overall, that actually reduces the dimensionality of the analysis considerably. But we still have a fairly complex signal, so we've only made a tiny dent in the overall job here. However, having done that, we can now obtain a time series such as this one, where we have on the y-axis body length, which, as I mentioned, is how we measure everything as a spatial unit, as a unit of distance. And then on the x-axis, we have frame number. It's trivial to transfer the frame number into a time, be it in seconds or milliseconds, because there's, for these videos, typically a standard frame rate of between 25 and 30 frames per second. So what we're able to do here is, first of all, we can identify all of the individual taps, and having identified the time point at which a tap takes place, or all of the taps take place, we can then measure the interval between taps, and that starts to give us a handle on things such as the frequency, which is what's being extracted here, because each of these intervals says something about the, as it were, instantaneous frequency. We can do something very similar for amplitude. Again, we've started by identifying each individual tap, and then we measure the amplitude from where the position at which the thumb tip and the fingertip are essentially pressed against one another, which is 0, up until they're at full extension when they're separated maximally. And here we can see visually that there's a decrement in amplitude. But what we can do, having estimated the amplitude and the frequency for individual finger taps, is we can then start to do things like plot trend lines. So here we're just doing something very simple, a form of regression on those amplitudes, in order to get an estimate of the overall reduction in amplitude that we see during this activity. So if we extract things like frequency and amplitude, which are, as we've mentioned, classic features of Parkinson's disease, in particular a reduction in frequency and a reduction in amplitude seen as disease severity increases, what we find is exactly what we would expect to find, that our metrics as we measure them suggest that people who get given a 0, so on the x-axis we've got people that were scored a 0 on the UPDRS for finger tapping. Those people that get a 0, they tend to have a higher amplitude, a larger amplitude, than those people who score a 1. And those people who score a 1 have a higher amplitude than those who score a 2 and 3 and 4 and so on and so forth. Exactly what we would see. And again, with frequency, we see a trend in the means, perhaps not quite so persuasive as with amplitude, but overall a downward trend in terms of going from mild disease to severe disease. So we can do the same thing for legs, just to check that it doesn't really matter what part of the body we measure, we get a similar pattern for each. And again, we see a very significant and clear reduction in amplitude, and again a comparable, less extreme but somewhat comparable reduction in frequency for leg agility, as we saw with finger tapping. So these are just kind of sanity checking, making sure that the data that we're pulling out conforms with what we'd expect from our sort of clinical knowledge and the observations that have been made about Parkinson's disease in the literature. Now, at this point, having extracted a bunch of what we think are at least informative features about Parkinson's disease, we can start to do slightly more challenging things. So we can start to say, if we just have the videos and we don't know what the clinical severity of the person's disease is, how well can we estimate that disease severity just using algorithms without any clinical expertise. And we do this using a class of models called regression models. So a regression model in its simplest form is where we have one input variable and one target variable. This is a univariate regression, or a single variable regression. And the idea here is that we know one thing and we want to infer another thing. So this might be in a general case, it might be if I want to infer what somebody's weight is from their height, then this might be useful information to infer what their weight is. But we might know more than one piece of information that's relevant, in which case we get a higher dimensional problem. So now we have two input variables. This might be height and waist size. And again, we're trying to infer some target variable, say weight. So now we have two pieces of information, and the idea is that we should get better at estimating that target variable the more features we put into the model. So if we use this class of models in this problem, what we're going to try and do is to set up a regression problem whereby we're going to take the specific items that people do in the UPDRS test, and we're going to try, and these are all specific items relating to particular activity in a particular location on the body, so in the hand or the fingers, and in the lower limbs, in the feet and the legs. And what we're going to try and do is take those specific items, and we're going to try and infer a global score of bradykinesia. So in item 3.14, and that's what the numbers in the brackets refer to, item numbers in the UPDRS, the part 3, item 4, part 3, item 5, so on and so forth. In part 3, item 14, asks the rater to give a global score, give an overall rating of the severity of bradykinesia for the patient across their whole body and across the entire examination. So we're going to take these scores and these videos that were done for patients doing these specific activities, and we're going to ask ourselves, how well can we infer what the global score for bradykinesia was? And we're going to use two techniques. We're going to use the clinicians' scores that they've given, and we're going to use the features that Kelvin extracts, and we're going to compare them and ask what's the best way of getting a good estimate of body bradykinesia. So if we try and estimate the score that was given by Kelvin, so we use Kelvin to try and infer what the score was, and then compare it to what score was actually given by the assessor, we can see this is a very good correspondence between these two. So when an assessor gives a score of 4, then Kelvin's very likely to give a score in a similar neighborhood. Of course, the thing to notice is that Kelvin is giving a score on a continuous scale, whereas the assessor is forced to give a score that's an integer value. So we're gonna ask ourselves, if we try and infer the clinical score from the clinical scores, if we're going to try and infer the value of item 3.14 from the values of the specific items, how good a job can we do? And I'll just take a few moments to explain this graph because I think it's an important one. So what we're asking here is we're asking if we take the CUPDRS, so we're taking the clinician's scores, so his scores between 0 and 4 that he or she gave, and we're trying to infer what score did he or she give for item 3.14 based on the scores that he gave for the specific items. So if we just use one item like finger tapping, then we can explain about 30% of the variance. We can predict some significant proportion of the time what that score is going to be, and when we don't predict it, we get sort of close, but not that close because we're only explaining 30% of the variance. And we do the same thing for hand movements, supination, pronation, toe tapping, leg agility, and so forth. We can do okay, but not very well. We find logically that if we combine two scores, so we're now turning this into a bivariate regression problem, we can do a bit better. If we look at finger tapping and pronation, we can explain 43% of the variance. And if we look at finger tapping and leg agility, then we can explain 53% of the variance. And perhaps that makes sense because we're now taking one score from the upper limb and one score from the lower limb, and arguably they should have more independent information across the pair than say finger tapping and supination and pronation, which are two hand-related examinations. And then again, logically, if we combine all of these features into one regression model, we can get to a total of about 62% explained variance. So that's as well as we can do in terms of predicting, getting an overall score of bradykinesia by using the clinician scores for those specific activities. So we can now give Kelvin the same problem and ask Kelvin to predict what did this assessor give for item 3.14 on the basis of the features that you've been able to extract from the video clips for the finger tapping, hand movements, pronation, supination, toe tapping, and leg agility. And what we see is if we do that, we can again explain a small amount of the variance from an individual video and the features we extract from it, some of them more than others. If we combine finger tapping and leg agility, say, we can do a little bit better. And if we combine them all together, then we can get up to about 53% of the explained variance. Now, the thing to remember is that this is not really a fair comparison, because in this instance we are using the clinician scores for items, the specific items, in order to try and infer the clinician score for the overall level of bradykinesia for item 3.14. In this case, we're using Kelvin's extracted features from the video in order to try and extract the overall score that was given by the clinician for item 3.14. So we're using the clinician's data to predict the clinician's global score, and we're using Kelvin's data to predict the clinician's global score in the second case. So it's not really a fair comparison if you want to look at the 53% versus the 62%. However, what is interesting is if we combine these two sets of features. If we combine the clinician scores that are given and the features that Kelvin extracts, and then we look at this as a high-dimensional regression problem. Here we've got many more than 5 features, because we've got all of Kelvin's features plus all of the clinician scores that were given. We can then get up to nearly 70% in terms of explained variance. And what this is, to sort of step back and sort of summarize what this is saying, what this is pointing towards is the idea that actually the human assessor is almost certainly accessing forms of data, perhaps sort of Gestalt kind of higher level pieces of data that the machine is essentially blind to, i.e. independent data sources. And the machine likewise is accessing data, perhaps features that are present only at very, very high temporal and spatial resolution, for example, that the human assessor is essentially blind to, i.e. independent information again. So while there is some redundancy between the data that these two systems are collecting, the human and Kelvin, there is also independence, and a significant degree of independence, because we can see that we can do significantly better than either individual test by combining the features together. This slide just basically makes the point that it doesn't really matter how we slice and dice this. This phenomenon is always seen to be the case. So if we only include one test, then we get a fairly low predictive power. But and as we increase the number of items that we use in solving the regression problem, we get better and better performance. But the important point to appreciate is that in every case, the combined Kelvin plus clinician, the C plus K UPDRS, is superior to either test individually. Now I just want to back up a little bit and talk a little bit about some of the data and why we think what Kelvin is extracting is really the same kind of clinical signal, so that we see in the clinical data. So on the left side we have what's called the correlation matrix for the scores for the KUPDRS, for the scores that Kelvin is giving. And what this is basically each row corresponds to a particular item in the UPDRS, and so where we have the diagonal, it's an item being compared with itself, so the correlation is 1 and not interesting. But where we have anything that's off diagonal, it's asking the question, what's the correlation between, say, finger tapping, which is represented by row 1, and say leg agility represented by column 2. So each row and each column correspond to a particular item. So row 1 and column 1 correspond to the same item. Row 2 and column 2 correspond to the same item. Likewise for 3, and so on and so forth. So and that's why this is diagonal and symmetric as a matrix. for those that are interested. But the point is, the deeper point is that when we look at this for either Kelvin or for the clinical CUPDRS, we get a very complex, what we call correlation structure. So this is not just a sort of grey soup. There are some instances where there's a very high correlation, such as between these two items, and other items where there's a much lower correlation, where the colors are a lot darker. So that's what creates this complex correlation structure, and it characterizes the overall clinical signal in a way that we feel is really very rich and very unlikely to be imitated by chance. And the way that we assess that sort of objectively is we can take these two correlation matrices and we can compare them item by item, and then we can plot the item by item comparisons on a scatter chart, scatter plot, and ask ourselves, what's the correlation between these correlation matrices like? Is it a non-random and high correlation, or does it look like the kind of thing we would get from just two randomly selected and unrelated correlation matrices? So for each one, each pair of elements corresponds to a single point on the scatter plot, and we go through all of the elements, plotting their various positions. And what we end up with is a scatter plot where each point corresponds to one of these comparisons. And then we can ask ourselves, what's the correlation between these two? And we see that there's a significant, and when we calculate the p-value, extremely significant correlation between these two. So we think this is relatively strong evidence that the pattern, the characterization of the disease, the pathological signal, if you like, that's being picked up by the KUPDRS is the same in essence as the pathological signal is being picked up by the CUPDRS, and that's why the pattern of correlations corresponds between the two forms of examination, if you like. This is a very simple figure that just makes the point that our system gets better and better as we feed it more data. What we've done here is we've artificially reduced the number of data points that we have available to train the system, and then we train the system, test the system, increase the number of data points, train the system, test the system again, and so on and so forth. And what we see is we get this very characteristic signal, which suggests to us that as you increase the number of data points in the early stages, you get a very big benefit in terms of performance, and then that levels off into a much more linear regime. But the gradient is still extremely encouraging, and what we think this shows is that as we feed our system more and more data, there's every reason to think that the performance will just increase in quality. So in conclusion, I just want to make 4 main points about Kelvin, which can be summarized by the acronym SAIL. Kelvin is secure. We haven't talked about it, but we are compliant with HIPAA and the GDPR, and we've been very happy to share our documentation and our SOPs on how exactly we've done that with anyone that's interested at Lookback. So your data is safe. Kelvin is accurate in that it has the ability to reduce both variance and bias in clinical assessment. And correspondingly, while this is probably not something that we're going to see in the first few trials in which it's deployed, we expect Kelvin to result in a dramatic reduction in the power required to test a particular hypothesis in PD research. We expect our clinical trials to be significantly smaller, and we expect them to be significantly faster using this technology. Thirdly, Kelvin is intelligent in that it has the ability to learn from data and to improve all the way up to the physical limits of possible performance. That's where we intend to take it. Finally, on a pragmatic note, Kelvin is low risk. We have built Kelvin. Kelvin has been built by clinicians and engineers who have lived and worked in this area and understand the overheads in adopting a new technology, and that clinicians are already busy, patients are already overburdened with having to come in and perform assessments. So we've made Kelvin as consistent and seamless with current practice as is humanly possible. So in terms of the clinician-patient interaction, there is almost nothing new and scary in Kelvin. It's almost completely consistent with current practice. So with that, as I said, I'd be happy to take any questions. Obviously this is not live, so if anyone would like to drop me an email at Jonathan, Jonathan, at machinemedicine.com. Machine medicine is all one word. I'll be very happy to respond to the question and get back to you as soon as possible. Cheers. Thanks very much.